Good morning, everyone. I am going to talk on managing drug toxicity of optic nerve. So if you know that it is a drug toxicity, there's nothing to manage. Just stop it. And I think that's the treatment. Okay. I'm done with my talk. So toxic optic neuropathy is visual impairment due to optic nerve damage caused by a toxin, which could be a drug. So the papillomacular bundle damage is the most common cause why you get a ceco and centrocecal defects. And patients don't reveal this history because most of the times they think that that history is irrelevant to their visual presentation. So you have to pull out that history of having that drug which is the causative agent behind the vision drop. So identifying the causative drug is the key for the toxic optic neuropathy because it presents painless, progressive, bilateral visual loss. So you have to be careful when a patient presents like that, and color vision loss is usually disproportionate to the vision loss, and it can range from a relative scotoma to total blindness. Most commonly they present less than 2400, and bilateral presentation causes a bilateral sluggishly reacting pupil. And RAPD is very, very abnormally seen, particularly in an asymmetric presentation, you may end up seeing it. An optic disc can be normal to swollen to or hyperemic. Sometimes we can see even disc hemorrhages, and temporal and diffuse pallor are the most common presentations. So disc chromatopsia is the first symptom, particularly the red disc saturation. And remember, toxic optic neuropathy is always a diagnosis of exclusion, and you have a whole list of these differentials for you to come before making that diagnosis for that patient. And the common causes of toxic optic neuropathy, coming to the drugs, are this huge list of drugs in which I have highlighted the most common drugs which we see in our day-to-day clinical practice. And maybe I'll try to show some examples of those also, and do a detailed optic nerve function test as shown here. And maybe you can add electrophysiological test, OCT, visual fields, Amsler to aid the diagnosis. And as I mentioned, because it's bilateral presentation, do not search for a relative afferent defect. It will be a sluggish response in both the eyes. And VEP can have a normal latency at times in the early stages, but it has a grossly reduced amplitude. And ERG, it can be both full field as well as a multifocal. Remember to use a multifocal ERG when you are suspecting a retinal toxicity versus an optic neuropathy in a central scotoma. So this is I'll be showing few cases. In this, the first case is a 44-year-old female who came with the complaints of progressive drop in vision in both eyes over 2 months. She had 3/60 vision with a dropped color vision, bilateral sluggish pupil, and anterior segment, and the fundus was almost near normal. And there she gives this history. So she was on ATT and she has stopped recently over 10 days back. And this is her visual fields. You could see a dense central centrocecal, and which is predominantly in the temporal quadrants. And yes, that's a toxic optic neuropathy secondary to ethambutol. So ethambutol toxicity is quite common and it gets missed also. So we stopped the ethambutol and her vision improved within 3 months to 7.5 to 6.9 in both the eyes, along with the improvement of the visual field. So ethambutol toxicity can happen almost in 6% of patients on ATT. It's dose dependent and duration dependent, so watch for it. And most common visual fields are, as I said, and we can see also a bitemporal defects in few of them. And prompt discontinuation should lead to an eventual visual improvement mostly, but what we have seen is a gradual pattern of recovery in our patients. And this is a study which we did in our institution, and we found that the ocular toxicity was quite higher in elderly, with low BMI, with immunocompromised status and poor renal function. And remember, it has a very gradual recovery pattern. So just keep the patient in a close follow-up with supplements. So this is case 2 who was referred as an optic neuritis. He was a 53-year-old male. He had a drop in vision in left eye for 2 months. And he had some cardiac ailment for which he was on treatment. He didn't carry the reports. He was in hypertensive. And by the time I saw, he was already post IV steroids. So this was the vision, and this is the disc appearance. He came with the left eye presentation, but you could see the right eye is also not normal, and he's having an inferior defect with a color drop, and pupil is still sluggish, and he is totally unaware of the right eye. He came only with the left eye. We did a complete atypical workup, and then when we went through the reports, this was the added drug for him in the last 6 months. So he says that probably he had some drop in the right, which he was not very symptomatic. You have to remember about this drug when you see patients on cardiac problems. because it's very difficult to differentiate an amide or an optic neuropathy versus an NAION because they have the similar risk factors. So this is one differentiating male preponderance, insidious onset. You will see a normal to large cup as opposed to a crowded disc in an NAION. It's mild vision drop. The patient didn't even know that he had a drop, and it's a protracted disc edema. I saw the patient after 2 months still sitting with a disc edema. That is one thing which is going more in favor for an amide or an optic neuropathy. This is the third case where he was being treated for TB for years because he was a MDR TB, and this time he came with a 2 months vision drop. He had bilateral drop, bilateral color vision, and both the pupils were sluggish. And this time he was on this second line drug treatment because he has already completed the first line and he is senior in the treatment. So now he has moved on to the second line. So this is the disc. So he had a very crowded, very subtle disc, but still it was pink. And you could see that central scotomas in both the eyes. And here the culprit was linezolid. Because the patient was on the second line. Remember, linezolid is always given as a second line therapy in our TB treatment. And this is after stopping the linezolid, there's an improvement in the fields. So linezolid usually is given as second line drug, and it causes its toxicity 5 to 10 months later. And most of the times by stopping you will have an improvement in the vision, but we see the visual field effects persisting for a longer period of time. And it is a mitochondrial dysfunction. And if you remember, even a patient who is on linezolid is prone to develop Leber's hereditary optic neuropathy. A patient who is already having a tendency to go in for mitochondrial dysfunction, it will just aggravate if he is going to be put on linezolid. So this is the last case who was referred to us as an optic neuritis again, and she had a bilateral drop in vision, but she was too symptomatic. If you could see this, it's a very subtle temporal pallor and a very minimal field loss, but the patient was very symptomatic. So the patient was actually referred to us for the second line of optic neuritis treatment. But looking at this fields and the vision, I said, no, there's something else which is going missed. And her VEP was also having a reduced amplitude, and that's the ERG. She had a bilateral gross reduced scotopic and photopic responses, and MFERG is also showing a gross foveal parafoveal response reduction, and that's when she gave this history. She was on chloroquine for a longer period. She was having frequent episodes of fever and joint pains, and that's the chloroquine toxicity of the macula and not an optic neuritis. So remember, differentiate all these factors. So while most of the drug-induced optic neuropathies can reverse when the offending agent is discontinued, there could be some amount of visual loss which is persisting, and the detailed drug history is very important. Remember to note down the dose and the duration, and always a bilateral progressive symmetric vision loss. You have to consider drug toxicity in the differentials, get the history out of the patient, and a contrast enhanced MRI may be required at time to rule out the other causes. So identify the agent and stop it. That's the treatment. Thank you so much.
Thank you.